Good day, everybody, and welcome to this USAID Infectious Disease Detection and Surveillance Project webinar on decentralizing laboratory services to increase access to diagnosis of infectious diseases. All attendees are in listen-only mode, and questions can be asked by text in the webinar platform. The webinar is being recorded, and everyone who is registered will receive the recording by email later this week. Our project fact sheet and a brief are available for download on the panel to the right of your screen. I'd like to introduce Amy Piatek of USAID's Bureau of Global Health, who will be delivering our welcoming remarks.
Thank you, Tom. Really appreciate the introduction. Hello, everyone. Like Tom said, my name is Amy Piatek, and I'm so pleased to be welcoming you all to this webinar today. I am from USAID, the Bureau for Global Health, sitting in the Infectious Disease Office, and I'm the COR, or the manager of the Infectious Disease Detection and Surveillance, or IDDS project that started back in 2018. Our vision for this project was kind of quite simple. It was really to ensure that countries have the capacity to detect infectious diseases of public health importance accurately, rapidly, and as close to the population as possible. Now, while that might seem like a simple thing to try to accomplish, there are many challenges along the way. And this goal, or this vision of having diagnosis, as close to the population as possible, has never been more important than now, as the world continues to grapple with many issues, especially the continuing COVID pandemic, the different Ebola outbreaks, and many other infectious disease outbreaks that we have seen across the world. Decentralizing diagnostic services is a core component of this project because it's a key pathway to enhancing host country capacity to reach populations at regional and sub-regional levels with timely and accurate laboratory services. Reliance on the diagnostic systems has figured prominently in the past 2+ years with COVID, and much more broadly with global health security, as countries strive to better detect and respond to outbreaks and improve pandemic preparedness. As we will hear today from this distinguished panel, the diagnostic network is very broad, and it encompasses many elements, many of which we won't even begin to discuss today. Some of these are the consistent guidelines, the protocols, the quality standards and processes, the supportive supervision, monitoring, specimen transport systems, equipment, and so much more. So I'm really happy today to note that IDDS and its vast consortium of technical partners has been very well placed to focus on decentralized diagnostic services. And we're going to hear today about the experiences, some of the lessons learned, and some of the impact thus far, and moving into the future. So thank you so much again for participating and being at this webinar. And I'd like to turn it over to our facilitator, Nisha Marles. Thank you.
Thank you so much for those welcome remarks, Amy, and for providing context to the topic that we'll be discussing today. My name is Nisha Marles, and I will be facilitating the webinar. First, some additional introductions. Next slide, please. Here's our lineup of expert speakers and panelists. We have included the speaker bios and their contact information ahead of their sections in the subsequent slides. In addition to the speakers, we will have two expert panelists, Ebi Bile and Cyril Kulaya, who will be joining us for the Q&A and discussion portion towards the end of the webinar. Next slide, please. We will be led through the webinar today by our excellent facilitator, Dr. Anise Daourou, the diagnostics lead for IDDS. I will now hand it over to Anise to walk us through opening remarks, the goals of our webinar, and our topics for this session. Over to you, Anise.
Thank you, Nisha. Next slide, please. I welcome you all into today's IDDS webinar. And infectious disease disproportionately burden low resource settings and good quality microbiology is a prerequisite for effective infectious disease control. But low resource settings face infrastructural, technical, and behavioral challenges when implementing clinical microbiology. Thanks to many vertical programs, the capacity effort usually focus on vertical disease program that have considerably improved the clinical laboratory services in some low resource countries. But as I said, they were focused on vertical disease like HIV, TB, or malaria. These vertical programs put in place some critical frameworks for diagnostic, as well as educating laboratory staff as to how to implement some of these vertical programs. But most of the clinical microbiology are performed in at the lower level of the diagnostic network by non-microbiologists, because not all laboratory technologists have gotten the right training to perform clinical microbiology. Because of the lack of good infrastructure, specimen cannot be moved from the peripheral regions to the capital city, where most of the clinical microbiology are taking place. These result in a very long turnaround time, time to provide the right clinical care to the patients. Establishing a decentralized model for clinical microbiology in this context of long specimen transport time, specimen integrity during this long transit to the testing facility to IDDS makes sense. And we made it a commitment for the project to provide decentralized capacity building and decentralized microbiology capacity to some selected priority countries within the project. And the IDDS project focused on 4 indicators of the global health security laboratory system package: the capacity to test country priority pathogen, the development of a system for specimen referral, development of a tier-specific diagnostic testing capacity, and finally, the quality management system in this action package. Next slide, please. What are we trying to achieve today is first present some of the advantage and challenges that decentralizing the microbiology or laboratory capacity face, and second, share the IDDS project decentralization strategies and experience in some of the few selected countries that we want to present today, and finally touch on some next steps. Next, please. Today, we will open with Dr. François-Xavier Babin. François-Xavier is the Director of International Laboratory Services with one of the IDDS project technical partner, Fondation Mérieux. François-Xavier is based in Lyon, France, and François will be presenting on the project support for tier-specific testing for an effective national diagnostic network. François' presentation will focus on the IDDS work in Madagascar, where the Fondation introduced the concept of a network with Resamat. And another country of focus for Fondation Mérieux is Guinea, where Francois will also present other aspects of clinical laboratory services that is pertain to regional and prefectural facilities in Guinea. Then we will hear from Dr. Mutonga David. Dr. Mutonga is the team lead for the IDDS project in Kenya. And as such, Mutonga and his team support Kenya Ministry of Health to develop standardization of laboratory workforce development tool. We will hear from him, and you get a chance to ask him as many questions as you would like to ask. And finally, we stop with Dr. Muij in Cameroon that will present on how to harmonize the laboratory processes. So I'm handing over to Nisha now for the rest of the today's topic.
Next slide, please. Thank you. Thank you, Anise. And as he mentioned, we will now begin with a session led by Dr. Francois Xavier Babin from the Mérieux Foundation. He's the Director of International Operations. As Anise mentioned, the foundation is a current partner and key player in some of IDDS's country programs, which is why we asked him to come and share his experiences and expertise from the field. Please, Doctor, go ahead.
Good day, everyone. Thank you, Nisha. Thank you, Anise, for the invitation for me to participate to this webinar. So next slide, please. So indeed, I'm going to speak about two experiences that we have. One in Madagascar with the Resamat project, on which we are collaborating with the IDDS project. And the other one about Guinea, the Labogi project. So both are about the decentralization of laboratory services. So I will speak about the impact of decentralizing these laboratory services in these two contexts, and also the key lessons that we learned so far in order to achieve this. I will speak for 10 minutes, but I could spend hours and hours to speak on this topic. It's very broad and difficult, so I will try to do my best. Next slide, please. So the Labogi project, so it's a project that is almost over. It's going to finish at the end of the month. Actually, it's funded by the French Development Agency. It's roughly 7 million projects that last for the last 5 years. The objective, so it's to implement the national policy for clinical laboratories and to decentralize the capacity of clinical laboratories in 33 prefectural and regional hospitals. So you can see on the slide on the right part the map of Guinea and where all the laboratories are. The objective is to set up the minimum package of laboratory services that are into the policy in all the laboratories in order to improve the access to the patients of laboratory services and to improve their care through the health system. The second objective also is to improve the laboratory system and to improve the laboratory-based surveillance and the access to the samples and the patients in case of any public health event of importance. Next slide, please. The second project, so, is the Resamat project. The objective is to strengthen also the services of clinical laboratories and to create a network with all these laboratories. So far, there are 24 laboratories that belong to hospitals participating to the network, and 13 of them are carry out bacteriology activities, which is even more important. Bacteriology at the moment is one of the key activities to fight against antimicrobial resistance. And we've seen so far with the development of the vertical approach of the vertical programs, you have more and more laboratories that are able to carry out molecular biology activities, and most probably now at the moment more laboratories that are able to do molecular biology, PCR in other terms, than laboratories that are able to do bacteriology, which is key so for AMR. So the impact of Resamad, the first one is to strengthen the quality of the services that the laboratories are delivering, which is very important. To have a result is good, but you need to know the level of quality of the results, otherwise it's kind of useless. It's also the improvement of the relation, the working relation between the clinicians and the laboratory. Most of the time before, the clinicians didn't trust the laboratory at all. And so the question was, what's the point to invest into laboratories if they are not used into the clinical practices or into the public health activities? So with the project, we can see really a good working relation between the clinicians and the laboratory, and the fact that they are using this tool for their daily activity. The antimicrobial stewardship also is improved a lot, actually, with the results that the laboratory are providing. There's an active participation of the network into the definition and the implementation of the National Action Plan for Antimicrobial Resistance. The laboratory is the only source of information, actually, to provide data regarding antimicrobial resistance. So it's really key to see the impact of this National Action Plan. But also, it's very important to change and to adapt the antibiotic recommendations for the patients. And it's also the source for the surveillance of AMR through especially GLASS, so GLASS AMR and GLASS tricycle that are being organized by WHO. And again, the decentralization is key because the data are representative not only of one city, but it's representative of the whole country. Next slide, please. So having talked about the impact of the decentralization, now the key question is how to decentralize. For me, one of the first lesson is the ownership by the stakeholders, the local stakeholders. It's really key, and in both projects, and especially in Guinea, the design of the project, the implementation was done directly in line with the national authority. In this case, with the National Directorate of Laboratory Services of the Ministry of Health. So this is the first thing, to make sure that locally, nationally, they are empowered into the project, and so they can use it in the future. Next slide. The second key lesson is the cross-cutting approach. It's very important to focus on all the steps that conduct to good laboratory results. It's like a chain, and you need to make sure that all the links are good, otherwise it's not going to work. Laboratory, as I always say, is a service, not a product, and so you really need to keep this in mind. Next slide, please. So I'm going to develop a bit about this cross-cutting approach. The first one is the infrastructure. So in both projects that was done, is a construction of rehabilitation of laboratory. It's very important for the well-being and the motivation of the laboratory staff. It's also key to improve the biosafety, the biosecurity, the work strain, the waste management, and also to think, of course, about the power supply. Next slide, please. The second point is the staff, the human resources, which is also very important, especially when we are talking about infectious disease, and even more when we are talking about antimicrobial resistance. There's a need of expertise to make sure that the translation of the technical results into clinical information is done, and is done properly, to use the laboratory results. So it's about having training, technical training, mentoring. To work into a network is also a very good source of motivation with the sharing of experiences, the establishment of the community of practices, and the fact also that they are working on common projects. We can also mention an emphasis now regarding the training of laboratory professionals, especially with the development of the GLLP, the Global Leadership Laboratory Program, that is focusing not so much on the technical skills, but much more on the soft skills of the laboratory manager. And I'm very glad to see it. Next slide, please. The next step of the approach is the management and the sustainability. Sustainability is really key, and it's something that is quite complex, actually, especially in low-income countries. So there's no any magic solution, if I can say so, but to see what are the different levels on which we can play to make sure that the equipment is chosen accordingly, to make sure that this is not going to cost a lot in terms of reagents, that the maintenance is going to be easy to have access to work on the cost recovery systems, and again, to train the management of the laboratory on the efficiency and on a good management. The example I put on the slides, it's the laboratory of bacteriology that we set up in one of the national hospitals in Madagascar. And with a kind of recovery system, 80% of the incomes are going back to the laboratory, 20% for the hospitals. And so with that, they were able to maintain their activity. So you can see the level, the amount is quite low, but still this was compatible with the activity of the country. Next slide, please. So the last point of this approach is the integration into the national laboratory system, and to make sure that what is done in one part is part of a global picture, is part of a global process, and participates to different kind of efforts, thinking about the national transport system, and thinking about the organization of all the laboratory services, and on the capitalization of experiences also. So to conclude, I just put some data, a bit old, but still didn't change much since this time, about the level of resistance that you can see in some places in Madagascar and those that we have in France, just to show that the problem is not a problem in our countries, but it's really a problem of low-income countries, and that shows the emergency to improve the laboratory services. Thank you very much for your attention.
Thank you, Dr. Baba, for walking us through your take on this cross-cutting approach. And now here is our next speaker, Dr. David Mutunga, to speak about his experiences of decentralizing technical capacity across Kenya. Welcome, Dr. Mutunga.
Thank you very much, Nisha, and good day, everyone. Thank you for the opportunity to share our experience in Kenya on decentralizing laboratory services. Next slide. Kenya is one of the countries in the East Africa region, and the population, estimated population in 2019 was around 47.5 million people. It has a devolved system of government with the national government and 47 counties. And since 2019, July, IDDS has been working with the national government in Kenya and 5 of the 47 counties to strengthen bacteriology diagnostic capacity in 4 county and 1 sub-county public hospital laboratories. The 5 counties are shown on the map. 2 of them are in the western part of the country, 2 at the central part, in the central, and 1 down at the coast. And the National Public Health Lab, which is at the capital city in Nairobi, is where most of the referral bacteriology referral services are done. And besides strengthening the diagnostic capacity, we've also been working together with both the national and the counties to promote utilization of that capacity to inform both clinical management of patients as well as contribute data for AMR surveillance. Next. We started with a baseline assessment of the capacity of these labs to test for antimicrobial resistance, and that was followed by a joint action planning with the national and the county levels, the 5 counties, based on the findings of the assessment. Then we did implementation, and we've been doing review and improvements. I will describe some of the actions that we took, some of these components in the following slides. Next. So the baseline assessments was done between July and August 2019 using the laboratory assessment of antibiotic resistance testing capacity tool. This is a USCDC tool that was developed with the support of USCDC. It covered 12 technical areas and 1 safety appendix, total 13 areas and not 15. We found at the time that 1 laboratory was not doing any bacteriology work at that time. 4 were doing bacteriology work, but inconsistently and with major gaps. And the graph shows the findings or the scores in some selected areas that were assessed, mainly the area of quality assurance and the quality control, which has been broken down into quality control for the media used in the lab, quality control identification, organism identification, QC, and microbial susceptibility testing, and the basic EST, and also the average score. Like you can see, except the site which has the orange bar, the others in some of the areas and they were literally not doing much and 0 scores. And next slide. So the first thing we did in terms of strengthening the technical capacity of these sites was to standardize the training materials that were being used in the country. This was included in an AMR surveillance training curriculum with both the facilitator and the trainee manuals. And then we trained some TOTs at the national level. The core ones were 14, but also the training included other multidisciplinary teams who needed to also have this information. This was followed by training of the sites using different strategies. This included hands-on centralized training at the National Microbiology Reference Lab and at the Aga Khan University Hospital Laboratory in Nairobi. A total of 15 lab technicians were trained from these 5 sites. And that was followed by sensitization and training of multidisciplinary teams in all the 5 counties. For the last 3 years, a total of approximately 471 people have been trained. And then the diagnostic specialists have been doing jointly with the national teams on-bench mentorship and the training of the laboratory technologists working in these sites. And the photo on the top right shows the launch of the curriculum by the Chief Administrative Secretary in the Ministry of Health. And the other photos are for the various mentorship or training sessions at different sites. Next slide. The other strategies that were used to build capacity included having these technologies rotate in one of the labs at the national level with good microbiology services at the Aga Khan University Hospital for 2 weeks, continuous medical education of different teams, including clinicians, nurses, pharmacists, lab techs in those sites, and both to strengthen diagnostic services but also promote utilization of those services. The sites have also been actively participating in the national public health labs, extension of community health outcomes, that is echo sessions. They have been preparing cases and presenting and receiving peer feedback as well as experts feedback. We've also been doing webinars, at least 2 every year, on the areas we identify as areas with gaps, as we do mentorship and supervision in these sites. Also, they have participated in preparing abstracts and presenting in scientific conferences, especially at the national level, and also during Kena's assessments. Next slide. We, in the process of working with the Ministry of Health and USAID funded projects called the Health IT to increase access to the trainings by hosting the training materials on the Ministry of Health Virtual Academy for self-paced online learning, and also worked with professional regulatory bodies to accredit the course so that the professionals can get CPD points when they undertake these courses. And as of June this year, around 564 people and access the training and at different levels in terms of completion. Next. So some few of the key outcomes. 4 of the 5 sites have earned their bacteriology services or tests included in their scope of accreditation to ISO 15189 status by the Kenya National Accreditation Services. These become some of the very few public labs, especially at the subnational level, to take this step. 4 of the sites also have acquired automated equipment to improve efficiency. All the 5 sites are currently generating and submitting EMR surveillance data to the national level. The country reported to the WHO Global Antimicrobial Surveillance System for the first time last year. The data from 4 of these sites out of the 6 sites that reported was included in that report. In one of the sites, private facilities are referring specimen to the county hospital lab for testing, therefore bringing services to more people. And as of April this year, a total of 8,229 culture tests and been done, and 1,983 organisms isolated in these sites, as can be seen in the bar graph there. Unfortunately, we don't have the data for 2019 to show the trend, but it was very minimal since only 2 sites were generating and reporting some data. Next slide. Some challenges, issues of staff attrition and turnover, which means sometimes, again, we have to work with to train more people to continue doing the services. When we started working, one of the key issues was a lack of services, but currently these hospital labs usually report that the services they are providing are underutilized. They have the capacity to do much more. Limited geographical coverage, like I showed, we are currently working in 5 counties. The other 8 are covered by different partners. That is out of 47 counties. Issues of space, like you can see on the in the photo on the right, some of the sites have very limited space to be able to comfortably do the testing. Thank you.
Thank you, Dr. Mutanga, for sharing your insights from Kenya. Now we will have our final speaker, Dr. Mokhtar Muish, take us through his presentation on standardizing best practices in bacteriology labs across Cameroon. Go ahead, Dr. Muish.
Okay, thank you, Anisha, for giving me the floor. Good day, everyone. Thank you for this opportunity to share the Cameroon experience on standardizing bacteriology laboratory practice. Next slide, please. IDDS is assisting the Cameroonian government to build laboratory capacity for quality services in detection of priority pathogen at the regional level and also at the district levels. One of the pillars for this decentralization process is to have standardized SOP in place for all the different laboratories. The interest of this approach is using this approach to standardize SOP is to ensure that we have good quality of diagnostic result, clear diagnostic process to reduce the turnaround times, and also to have an accurate data for IMS, antimicrobial resistant surveillance at national levels. Next slide. IDDS financial and technical support this approach. We use a four-step approach. The first step was to assess what's the existing capacity in the different laboratory in all the 10 regions of the countries. Now the second step was to develop the draft of the needed SOP and the different tools based on the different laboratory capacity. And the third step was to have a stakeholder validation to be sure that all the people are agree using their different tools. And now we have the fourth step was to dissemination, training, and supervision. Now this is very important that to have all the stakeholders engaged on this implementation approach. Next slide. Now, the first step were to conduct a laboratory capacity assessment. Now, we assessed 35 laboratories in the 10 regions of the countries, which have some minimal capacity to implement bacteriology testing. We use the CDC lab tools to assess 13 key technical areas, include quality assurance, quality control, processing, identification, and also antimicrobial susceptibility testing. We observed that in many of the laboratory assessed, they don't have adequate SOP in place. They are missing reference trend. They don't have any quality control procedure in place. Now, this was the main result we have after the assessment. Next slide. Now, after this, we chose to put in place at national level a technical working group, yes, to try to set up an harmonized standard operation procedure for all the work at the bacteriology lab. We include in this technical working group of the key national stakeholders, people from animal health, people of human health, university, laboratory, research, medical association, and also all the national partners who is involved in this kind of activity in country. On this new SOP drafted using the most recent recommendation for the different international guidelines. Next slide. The harmonized procedure developed includes procedure from sample collection, culture media preparation, identification of priority pathogen, antimicrobial testing, and also how the site can report data from antimicrobial resistant at the national levels. Next slide. We establish with the support and other in-country partner a One Health training at national levels. Now we start by reinforcing capacity of some government staff to be able to deploy the cascade training at the regional and district level in human and animal health laboratories. Now we train about 16 staff from the two sectors to be able to support the cascade training in the other laboratory in countries. Next slide. The workforce development is essential to improving capacity of laboratory staff on ammonia procedure in countries. We start the cascade training in 4 regions of the country. In these 4 regions, we train about 16 staff, laboratory staff in around 15 laboratories. So we are just at the beginning of this deployment process. The aim is that we have all the people, all the laboratory in the 10 regions using this new harmonized SOP. Donc, it's very important that the different lab put in place the SOP to show that they are compliant with the different international standard in terms of bacteriologic testing. They also implement internal quality control, and also many of the lab where we are already support, and also participating to an NS.
It seems like we lost Mokhtar. So the training on the mentorship where to improve turnaround time and to have the training decentralized at the lower level of the pyramid, as Mokhtar presented. So we started with the TOT training, and then the TOTs were cascading down at the regional level, so that to increase the number of staff trained on how to handle the microbiology specimen. Next slide, please. Thank you, and sorry for the loss of connection with Cameroon. Nisha.
Thank you, Anise, for filling in for Mokhtar. We've now reached the final part of our program with about 10 minutes remaining for questions and answers. At this time, we will have our 2 excellent panelists, Dr. Cyril Kulaya and Mr. Ebi Bile, join us for the discussion. If you have a question for any of our presenters or panelists, please feel free to enter them into the chat window, and we will direct them to the group for a response. Over to you, Anise.
We have a few questions, and I will start with, let's say, a general question to Dr. Mutonga first, and any other panelists can chime in as which. Dr. Mutonga, you touched on the lab microbiology stewardship, and we have a question on how was improved relationship between clinician and laboratories measured. How did you measure the improved relationship between the clinician and the laboratories?
Thank you, Anise, and the person who asked the question. The relationship between the clinicians and the lab personnel has been one of the challenges which affects utilization of the lab services, especially microbiology. And we have taken a number of steps to try and address this through the antimicrobial stewardship teams in the different sites where we are working. One of the things we've done is having joint meetings between the lab team and the clinicians, where we talk about the AMR surveillance, or the needs, why it's good to base clinical decisions on the lab tests. And one of the things we did, for example, in one of the sites, Kitale, that was doing not so well, was to try and come up with targets on the number of tests that the site needed to, for example, have. And then we've been monitoring this on a continuous basis. We also, the other thing we do is whenever we're having these forums, we share data, or we encourage the lab, provide an opportunity for the lab to share the data from that they are generating in the lab, including the resistant patterns, and sometimes why the drugs the clinicians are continuing to use without lab evidence. Some of them are showing resistance, and that has helped in a way to bridge the gap. But it's something that needs to be continued. Yes.
Thank you, Dr. Mutonga. I have a question for Dr. Cyril on how do you ensure that the supply are available and the country can procure microbiology supply in country. I know you haven't talked, but from my experience, this is something that you implement in Tanzania. Cyril? Speaking, you're on mute.
Thank you so much, Anisette. When the IDDS project started in 2019, we found that even the microbiology commodities were not captured within the National Supply Agency in the catalog. And what we did was to, first of all, engage the MSD and started the trainings of the laboratories which we are supporting with regard to forecasting and listing the critical microbiology commodities which needed to be captured within the national electronic logistic management information system. And we have been doing regular inventory and supply chain management mentorships and forecasting, and also having to update the necessary commodities within the electronic logistic management system of at the national level. And through this, the laboratories which are implementing the AMR detection and surveillance are able to monitor the supplies and also order the supplies in time to avoid the interrupted testing of the drug resistance, especially the antibiotics.
Thank you, Dr. Cyril. I have a question for all panelists as well about ensuring the quality of the test. How do you ensure that the decentralized result as of good quality as that's the one that the central laboratory could provide? Dr. Billet, if you want to start, or François Xavier.
Thank you very much, Anise. I think I will start. To ensure that this result of good quality in the lab where we decentralize bacteriology capacity, the main thing that we did in Guinea really was to establish a QC panel, proficiency testing panel, by working closely with the National Institute of Public Health, characterize samples, and send it to the labs that are performing bacteriology. So this one was done. We supported all the 5 labs that have those capacity in the country to make sure that the results are of good quality. So the first result that we have were very encouraging, even though we still have some work to be done, because that was for those just a reminder, a small background. In Guinea, those labs didn't have the capacity to do bacteriology, unlike in Kenya, where there were some labs that had that capacity. So we started really from scratch to establish the bacteriology culture and AST capacity in those facilities. So they didn't have the experience. So this AST helped us at least to have an idea of not only their performance, but also to see if the model and the training that we conducted was of good quality. So, and like I said, the first result that we obtained were very encouraging. So now what we are trying to establish is really to continue working with the National Institute of Public Health, not only them, but other partners, to really continue strengthening the capacity so that it's a continuous activities in the country. Thank you.
Maybe to complement the answer of EB, what we try to do to ensure this quality, so it's some testing or assessment of the quality, as EB mentioned, with the proficiency testing, and also a lot of trainings to make sure that the people in the lab, they will have this mindset of the quality, they will be aware of it, and they will start to implement it. And so it's actually the QMS, I should say, the quality management system, and to have this whole process that is set up into the laboratory. So it's a lot of trainings, of mentorship. It's also some audits to be done at sometimes to see the evolution, the level of performance. So there's a lot of different kind of tools to do it. And at the same time, so to have external quality evaluation, such as proficiency testing, or sometimes this is what is done within the RESAMA network, inter-laboratory comparison, when it's difficult to get access to international proficiency testing. At least one lab is providing some quality control samples, send it to the other labs of the network, they all carry out the examination, and then they can compare the results and they can see who is good, who is not so good, and they can also work on the causes of this and to try to solve the problems and to improve the capacity. So it's a very long-term process, but which is very important.
And I know all of the countries are also providing supportive supervisions. So they are traveling with the government staff to be working side by side at the bench, making sure that the laboratories are doing well. And this also a response to Sarah Page's question, what make our decentralized concept unique is to be providing mentorship at the bench, identifying the gaps and working with the said labs to fix the deficiencies that we identify in the field. We had a question here from Dr. John Sterling from the WHO Collaborative Center. John would like for us to comment a little on the IT piece of the process. As you know, the end product is the report. How do we ensure that that reporting is done correctly? How do we ensure the reporting is done to international settings like GLASS? And if you can comment a little on the laboratory information system that's been used in the system and the data quality. I will open up to you, Francois, data quality to Mokhtar, to Mutanga and Cyril, if I can have all of you try to just take 1 minute to provide something. Francois?
So the answer is going to be very short. Actually, I think John knows it. It's WUNET that is probably the best tool to use to this report. That's it. So it depends on the laboratory, on the size of the laboratory and the level of equipment. But to have laboratory information system is really important. There's more and more tools that are available for free now. WUNET is a very good example, which is at the interface between the intra-laboratory information system and the inter-laboratory information system, because this is the one that helps you for the daily activity of your lab, at the same time that helps you to provide the report at especially the GLASS format. So the idea is to use such tools and to find the best one according to your needs to make sure that the reporting system is up to international standards.
David, would you like to touch on the data quality?
Yeah, thank you, John. The site in Kenya have been using a lab information system, mainly labware, to transmit data from the surveillance site level to the national level. We've been doing with data quality audits in the sites to look at the data they're generating. And also once in a year, we do data cleaning and analysis jointly with the ministry at the national level. But recently, because some sites do not have a lab information system, we trained at the sites where we are working on UNETs. And at the moment, those that do not have a lab information system are using UNET to submit data to the national level. There are issues of integration between the UNET and the lab information system at the national level, and that is something that is being worked on. But UNET has helped to standardize data. Thank you.
Thank you, David. I want to touch on the sustainability. I'm getting some questions. What the project is doing to ensure that the countries will have can have funds to continue after the project ends. I just open to whoever wanted to touch first.
I can start. I think the first thing to start with is what Xavier mentioned in his presentation, like what they did in Guinea with Labogi, is really to work hand in hand with the government entity. So it's really to involve them, and from the initiation of the project and the implementation in the field. And that's what actually here in Guinea with IDDS, that's what we did. And now to make sure that it's sustained, that's where we all have a lot of challenge, because even though at high level of the government, they are involved in the process and they gave the approval and working with us hand in hand. One of them is the mobilization of resources. And so here in Guinea, what I think the Directorate of National Lab is trying to do with all partners is really to have a group of partners, a technical working group, including all the partners who are supporting lab activities in Guinea, so that we kind of put all the activities we are doing in the same basket and working hand in hand so that we don't duplicate activities. And so far it has worked very well. That's why I mentioned that, for example, with what Fondation de Rieu is doing here, and also Expertise France in terms of drug-resistant surveillance. We are working closely with them we work with them to develop some of the manuals and the guidelines, and also the AMR national plan. So to sustain really is all the partners who are providing funds to work together and under the leadership of the ministry, because definitely the ministry resources won't be enough to take over all the activities. But if it's done in a more collaborative way and under the guidance of the national policy, I think we can go far with the little resources that we have. Thank you.
Maybe, I don't know, Anissa, if I still have time to complete.
Yeah, just 30 seconds.
Yeah. So to complete again the EB answer, so there's two things on which we can have a lever. The first one is the cost of the laboratory examination. So to make sure that the choice of equipment, the choice of reagents is going to ensure a cost that is going to be as low as possible with good quality, of course. So this is very important to think of it, not only when you purchase it, but the cost of the reagents actually when you use it. And the second point is what are the resources available to cover this cost. There's different possibilities. There's all the vertical approach, for example, so the services that can be provided through international projects or international initiatives such as the Global Fund. And also through the patients. In many countries, actually, the patients are paying, or insurance, health insurance are paying, and so to see what would be acceptable by the population, and to make sure that it's going to be there's going an equation between the cost and the level of affordability. So this is quite difficult, actually, but this is the only way to make it sustainable.
Thank you. Thank you all. I want to take this opportunity to try in a minute and a half to summarize and wrap up. And one key takeaway for me today is the country ownership, making sure we have a stakeholder ownership from the conception to the implementation. And the institution on the top of the diagnostic network should be leading the conception and the operationalization of the decentralization system. A second point is making sure some of the prerequisites are there. What are them? The infrastructure, the manpower, and also ensuring that we have at least some sustainability piece while drafting the concept of decentralization. And as you've seen, we train within the project 700 plus healthcare workers on both bench, management, or practitioners that prescribe the lab test. And third, it is important to work with some kind of harmonized and approved tool. This is all the procedure and the policy that are needed to implement such work, and making sure the piece of equipment are not cheap, but are procured and could be maintained throughout the life of the project. And finally, ensuring that the supply is not interrupted. Again, the process can provide countries with preparedness and outbreak response, as the project, IDDS project, have shown in some of the countries where we work. In all of the countries that we present today, we've done some COVID-related activities just based on the groundwork that we conduct in these countries. In Madagascar, for instance, we got molecular diagnostic decentralized in one of the Rethamad facility. Other places, we use the training and the preparation that we had to ensure that specimen, COVID specimen, were transported to the right testing facility. And finally, just making sure the lab tech on the ground with the training on biosafety and biosecurity or quality management were ready to face enhanced Ebola surveillance in DRC or in Guinea. And finally, just to say thanks to the panelists that today take time to prepare for this webinar and have a great presentation for us. And also thank to you all that attend this webinar. You can have our address, contact information on the slide here, and do not hesitate at the end of today to reach out to us if you need anything from us that we can share with you. And please follow us on social media for our next webinars that will be sent out shortly. Thank you for your attendance today's webinar.